Glaucoma. Primary open-angle glaucoma. Symptom: usually asymptomatic until the later stages. Early symptoms may include parts of a page missing, tunnel visions, or loss of central fixations typically do not occur until late in the disease. Signs: intraocular pressure, IOP. Although most patients will have an elevated IOP, normally range of 10 to 12 mg per mercury, nearly half of IOP of 21 mg or lower at any one screening. Gonioscopy: normal appearing open anterior chamber angle on gonioscopic evaluations. No peripheral anterior synechiae. Optic nerve. See Figure 9.1. Characteristic appearance includes loss of rim tissue, including notching, increased narrowing superiorly, inferiorly, or nasally more than temporally, progressive narrowing over time, regional paler, splinter or nerve fiber layer hemorrhage that crosses the disc margins, which is a Drans hemorrhage, acquired pit, nerve fiber layer defect, cup disc asymmetry greater than 0.2 in the absence of a cause, for example anisometropia, different nerve size, bioting, sharp angulations of the blood vessels as they exit the nerve, enlarged CD ratio greater than 0.6, less specific, progressive enlargement of the cup, greater disc damage likelihood scale, visual field defects. Characteristic visual field loss includes nasal step, paracentral scotoma, acute scotoma extending from the blind spot nasally, altitudinal defect, or generalized depressions. Workup. History. Presence of risk factor, family history of blindness or visual loss from glaucoma, older age, African descendant, diabetes, myopia, hypertension or hypotension, previous history of increased IOP or chronic steroid use, refractive surgery including laser in suture keratomalysis or LASIK in the past, change in pachymetry, review of past medical history to determine appropriate therapy including asthma, chronic obstructive pulmonary disease, congestive heart failure, heart block or bradycardia, renal stones, allergies. Baseline glaucoma evaluations. All patients with suspected glaucoma of any type should have the following: complete ocular examination including visual acuity, pupillary assessment for a relatively affluent pupillary defect, confrontational visual field using a red object, slit lamp examinations, applanation tonometry, gonioscopy, and dilated fundus examinations with special attention to the optic nerve. Baseline documentation of the optic nerves. For example, stereoscopic disc photo, red-free photograph, computerized image analysis, an OCT, optical coherence tomography. Goldman visual field tests may be helpful in patients unable to take the automated test adequately. Color vision testing indicated in those suspected of a neurological disorder. Measure the central corneal thickness, CCT. Corneal thickness variations affect apparent IOP as measured with applanation tonometry. Average corneal thickness is 530 to 545 microns. Thinner cornea tends to underestimate IOP, whereas thicker corneas tend to overestimate IOP. Although the relationship between corneal thickness and measured IOP is not exactly linear, a thin CCT is an independent risk factor for the development of primary and open-angle glaucoma. Further evaluations for other causes of optic nerve damage should be considered when any of the following atypical features are present. Optic nerve pallor out of proportion to the degree of cupping. Visual field defects greater than expected based on amount of cupping. Visual field patterns not typical of glaucoma, for example, defect respecting the vertical midlines, hemianal defect, enlarged blind spot, or central scotoma. IOP within the average range, less than 21, or symmetric between both eyes. Unilateral progression despite equal IOP in both eyes. Decreased visual acuity out of proportions to the amount of cupping or visual or field loss. Color vision loss, especially in the red-green axis. If any of these present, further evaluation may include history, acute episode of eye pain or redness, steroid use, acute visual loss, ocular trauma, surgery, systemic trauma, heart attack, dialysis, or other event that may lead to hypotension. Diurnal IOP curve consisting of multiple IOP checks during the course of the day. Consider other laboratory workup for non-glaucomatous optic neuropathy. In case where a neurological disorder is suspected, obtain a magnetic resonant imaging MRI of the brain and orbits with gadolinium and fat suppression. Check blood pressure, fasting blood sugar, lipid panel, and CBC. Treatment. General consideration. Who to treat? The decision to treat must be individualized. Some general guidelines are suggested. Is the glaucomatous process present? Damage is present if the DDLS score is greater than 5 and there is a visual field loss. There is the presence of acquired pit or notching rims, irregularity of rims greater than 0.1, rim to disc for less than 2 clock hours, IOP higher than 34 millis per mercury, IOP asymmetry more than 10 millimercuries, or this is less than 1.5 milli with a C cup to disc of greater than 0.3. Is the glaucomatous process active? Determine the rate of damage progressions by careful follow-up. Certain causes of cupping may be static. This hemorrhage suggests active disease. Is the glaucomatous process likely to cause disability? Consider the patient's age, overall physical and social health, as well as an estimation of his or her life expectancy. And what is the treatment goal? The goal of the treatment is to enhance or maintain the patient's health by halting optic nerve damage while avoiding undue side effects of treatment. The only proven method of stopping or slowing optic nerve damage is reducing IOP. Reduction of IOP by at least 30% appear to have the best chance of preventing optic nerve damage.